My name is Daniel Solomon. I'm a professor of medicine at Harvard Medical School and a rheumatologist at Brigham and Women's Hospital. I'm also the editor-in-chief of Arthritis and Rheumatology. And I'm excited today to talk to you about changing models of rheumatology care. There's really a crisis facing rheumatology in the United States, and it's about three specific issues. First, timely access to rheumatic disease care is becoming more and more difficult. There's a limited supply of rheumatologists, rheumatology nurses, and physician's assistants, and patients are growing in age. The number of patients needing rheumatologic care is growing, and access is becoming a bigger and bigger problem throughout all of the United States. At the same time, we have a high-cost drugs that take weeks to work. This is a great development in rheumatology and for rheumatology patients, but the cost of these drugs and the duration of time that it takes for them to begin to work works against a system where access is very difficult. At the same time, we have little visibility to longitudinal patient symptoms. All of these things are addressable, but it's going to really take a change in the model of rheumatology care. These are some data that were published by the American College of Rheumatology on the availability of rheumatic disease specialists across the United States and how the ratios of available rheumatologists to populations are going down between 2015 and 2025. These trends have continued. There are increasing numbers of retirements. People entering the field are not working full time. And the number of people being trained just cannot keep up with the demand. At the same time, we have an expanding armamentarium of therapeutics. In the 90s, we had the introduction of biologic DMARDs. And over the last 25 years, there's been an explosion. I'm just showing you some data for drugs in rheumatoid arthritis, but there's a similar slide that one can create for psoriatic arthritis and even now with lupus. So the excitement for patients and for clinicians is tremendous to be able to prescribe these drugs. But when access is difficult and follow-up is difficult, use of these drugs becomes problematic. At the same time, we know these drugs are tremendously expensive. So I list here just a couple of selected drugs in RA, psoriatic arthritis, spondylitis, lupus, and vasculitis. And as any rheumatologist would recognize, these are commonly used drugs that cost tens of thousands of dollars per year. And without good visibility to the patient's longitudinal symptoms, it's difficult to justify prescribing of these medications. Again, we start a patient on a drug like a biologic or a targeted DMARD, and we're flying blind. My follow-up for a patient who's starting on a drug like this, I'd like it to be 6 to 8 weeks, but unfortunately, it's often 4 to 6 months. And in that time period, the patient's response to these drugs is not being charted. So again, the patient's flying blind, I'm flying blind. I don't know if the patient's adhering to the drug, having problems with the drug, or responding to the drug. So possible solutions to these access issues are first, trying to increase the number of rheumatic disease clinicians. Rheumatologists and advanced practice providers are what we usually think about. However, trying to train enough of these clinicians is just not manageable in today's training environments. We don't have enough training programs. APPs are being attracted to other fields. And so we're not going to be able to solve the access problem just by training our way out of it. We can try to enhance virtual visits and telemedicine. However, as one might quickly realize, it does not reduce the need for clinicians. Clinicians have to staff these virtual visits and telemedicine visits. And again, we're not able to train enough of these clinicians. It does improve access to patients who live in rural areas where there may not be a rheumatic disease clinician nearby. So this is an improvement in access for such patients, but it doesn't really solve the national problem. Better triage models are something that's been talked about for a long time in rheumatology. Ways of deciding when patients need to come in to see a rheumatologist or really are better seen by other clinicians for other pain syndromes, or perhaps the use of expensive laboratory panels, which might weed out patients who really don't have an immunologic condition. These are possibilities. However, training the clinicians to triage patients and the cost of these rheumatology laboratory panels is really substantial. So we've been working with colleagues here at Harvard Medical School and the Brigham to try to think about ways to change the care model. And we're really interested in thinking about ways to reduce visit frequency. We know that 1/3 of visits for inflammatory arthritis are in patients with stable symptoms. And face-to-face visits must be reserved for patients with very symptomatic disease. So these patients with stable symptoms, perhaps seeing them every 3 to 4 months is really inappropriate. Perhaps every 6 to 9 months would be more appropriate. But we need ways to understand if these patients are stable between visits. We think that patient-reported outcomes, PRO tools used between visits and integrated within the clinical workflow can help target face-to-face visits and improve access. This is what we've been working on through use of digital health technologies, integrating a mobile health application within the electronic health record, using principles of human-centered design to solve real access problems for patients and for the healthcare system. So we know that from studies in other countries, this is a study that was conducted in the Netherlands, published several years ago in Arthritis and Rheumatology, testing a mobile health application which collected patient-reported outcomes, PROs, between visits. It was a randomized trial in 102 patients with RA in the Netherlands, testing usual care versus a mobile app. And what they found was that the visit rate ratio was reduced in the patients who had the application. So the number of rheumatology consultations and nurse consultations was significantly reduced in patients who used the mobile app. And the clinical symptomatology was very similar over the course of a year in patients having usual care versus those having reduced visits because of the use of the application. This is a study from China. 2,200 patients with RA in China, half were randomized to usual care, half to use a mobile app. This study was able to actually show that there was a reduction in disease activity in patients who used the mobile app. And there was a slight reduction in the use of in-person visits as well. So we've taken these two studies as enthusiastic endorsements to pursue the use of apps in rheumatology. Back in 2018, I worked with one of my colleagues, Yvonne Lee, and we developed the first version of our mobile health application that we call MPro here at the Brigham. And obviously, the benefits for patients are trying to take the improved symptom control by using the app and communicating the results of the PROs directly to their clinician. The benefits to the clinician are more efficient visits. They have information on how the patient's been symptomatically between visits, easier and better communications. And when this is all integrated into the electronic health record, it really improves the clinical workflow. Our initial version in 2018 was not integrated in the clinical workflow. And over several years, we were able to integrate it into the clinical workflow in an app that we call MPro. MPro we've tested in a recent trial. 150 subjects used the app for 12 months. They all had rheumatoid arthritis. We compared them to concurrent matched controls. The endpoints that we looked at were process of care, visit frequently, satisfaction with care, and PRO results. This was published all in Arthritis and Rheumatology in the last year. And I just want to show you what the MPro looks like for patients. So a patient is prompted to answer a questionnaire. This comes up on their phone every other day or their tablet. They begin a pain questionnaire. These are all validated promise measures, short forms. So they're only 4 to 5 items. And then they answer the questions. And immediately upon answering the questions, they're given the results of their survey. So they can see whether they're in the green, doing really well, yellow, doing well, orange, not so well, and more severe in the red. So patients are given immediate feedback that they can understand intuitively using the slider. They also can see how they're doing longitudinally over time for pain, for fatigue, for RA disease activity, or for function. They have a Learn tab that they can get information on general arthritis, on the symptoms of rheumatoid arthritis, as well as they can learn about their medications. We give them a medication reminder tab. They input their medications. This is a patient who is on Rinvoq and using Tylenol. They can input the schedule with which they take these medications, and then the reminders pop, and they can mark whether they've taken it or not taken it. If they've not taken it, they're given a drop-down menu about why they didn't take it. Forgetting, not available, prescription information, prescription problems at the pharmacy, or insurance issues. And this information becomes immediately available to the clinician. So the clinician can see how their symptoms are, can see whether they're taking their medicines, and whether they're having any adherence issues. As well, we've integrated this within the electronic health record. So this is what it looks like in the RA PRO tab in Epic, which is the electronic health record we use at Mass General Brigham. We can see that this patient has been in the green or the yellow with respect to the disease activity. With respect to pain, they've been in the yellow and the orange. And this is the information that I show the patient when I see the patient in a face-to-face visit, and let them know that I'm following them carefully about their symptoms between visits. Not only do I have this information, but the MPRO application processes the information and gives some information to the clinician. So my colleagues, when I brought these ideas to them, they said, Solomon, it's great to use this, but it has to be simple. Can you process the data from the PROs coming from the patient? And so we created some logic within the application that gives these in-basket messages. These are within EHR emails that the doctor gets. And it tells the doctor if the patient might need an early visit, a delayed visit because the patient is very stable, or just a routine reminder that the patient has data in the PRO tab. When we tested this in our recent study, we found that there was a slight reduction in overall volume in the app patients compared to control. This did not reach statistical significance, but all the symptoms in the app patients were very stable over the 1-year period. So use of app and a slight reduction in visits was associated with very stable symptoms. So we were very heartened to see that. As well, patients found the MPRO easy to use. The app was easy to use, was rated by 95% of patients, for me to learn, 97%, et cetera. So patients find it easy to use, and they're very adherent with this. 60 to 70% of the time, they answer these questions over the course of 1 year. They find it useful on top of their usual care. So green tells us that the app would be useful on top of my usual care for my health and well-being, 60% of patients, et cetera. So patients like this, docs like it, patients are very adherent with it. And so we think this has a lot of promise, and we're starting to now move this outside of the walls of academic medicine. We have several community-based practices using this in South Carolina, North Carolina, and we're looking forward to seeing how it works out. So I think that some of the implications for this work are, first, the model for rheumatic disease care must change to provide adequate patient access. Better triage systems and more advanced practice providers can help, but require substantial time and effort. The smart use of digital health technologies can improve access and the rational use of expensive medications while improving care. Good patient and provider satisfaction suggests that PRO apps such as MPRO can be a routine part of rheumatic disease care. Providers need appropriate financial motivation. And the good news is that CMS has created some billing codes called Remote Therapeutic Monitoring, RTM codes, that do provide payments to providers to use the app and to review the PRO data. The PROs can help with CMS value-based care programs, and higher acuity patients provide better reimbursement. So when you forego a patient who's very stable and can bring in a patient who's very severe or a new patient, this actually adds to the bottom line of a practice. So we think this really has a lot of promise. And I thank you for your attention. And I thank many of the funders and many of my colleagues who have been so instrumental in making this work possible. Thanks very much.